Hello and welcome to this CPT podcast on heart failure. In this podcast we're going to talk about the emergency management of acute or decompensated cardiac failure and chronic cardiac failure, both its definitions and some of the important drug treatments. Once again, we're going to use this as an example of some of the most important drugs that are used in cardiology. In terms of other materials, there's another podcast that I've done on heart failure that can be found on the website at podmedics.co.uk. And we'd also like to recommend this article from the student BMJ in ABC of heart failure, its clinical features and complications, which provides an excellent overview of all things that are necessary to understand from the undergraduate perspective. For more detail, however, we'd like to recommend an excellent chapter in Davidson's Principles and Practice of Medicine on heart failure. So let's start by talking about decompensated cardiac failure. Decompensated cardiac failure is a medical emergency that's characterized by the acute onset of shortness of breath, together with signs of adrenergic activation, typically a tachycardia, and also often pink sputum. The important clinical signs are bibasal crepitations and a gallop rhythm. Treatment, as always, is directed towards A, B, C, and D. If you remember in the last podcast, I spoke about what each of these stands for, but just to recap, in CPT, A is for airway, B for breathing, C for circulation, and D for drugs. So in terms of the airway, you need to secure it. For breathing, you should sit the patient up and give oxygen, for example, 10 to 12 litres through a non-rebreather. However, if the patient is known to have COPD, you might want to consider using a Venturi mask and giving 28% oxygen. C is for circulation, and of course you should gain IV access and take bloods. Moving on to the specific drug treatments now, your basic aim is to vasodilate the patient, and to do this you use 3 drugs. Morphine, typically at a dose of 2.5 to 5 milligrams, plus an antiemetic, usually metoclopramide 10 milligrams IV. GTN spray, usually 2 puffs, or alternatively 2 small soluble tablets that can be given sublingually of 0.3 milligrams. And furosemide, a diuretic, between 40 and 80 milligrams IV. Morphine has an additional anxiolytic effect, which is very useful. And furosemide, as well as having an initial vasodilatory effect, later, of course, has a diuretic effect. If breathlessness is ongoing and this treatment fails to gain control of the pulmonary congestion, you can try using a nitrate infusion, provided, of course, that the blood pressure is greater than 100 millimeters of mercury systolic. If these therapies fail, you might want to consider using respiratory support, such as CPAP, using ionotropes, and also considering IV aminophylline. But these things are usually done at a specialist level, and you should be involving senior help. So, in summary, decompensated heart failure as a medical emergency, characterized by the sudden onset of shortness of breath, usually in a patient who's known to have ischemic heart disease. Important principles of management include giving oxygen and vasodilating, with nitrates, both GTN and infusion, furosemide, the diuretic, with additional vasodilatory activity, and morphine, which both provides vasodilatation and an additional anxiolytic effect. So now let's talk a little bit about chronic cardiac failure. I don't want to spend a long time going into the details of diagnosis, signs and symptoms of cardiac failure. I do want to talk a little bit about the New York Heart Association classification because this is important in management. Classification is divided into 4 classes. Class 1 is asymptomatic, Class 2 is with slight limitation to physical activity, class 3, moderate limitation to physical activity, and class 4, severe limitation. However, what do these slight, moderate, and severe really represent? I like to think of it as slight being breathlessness on the climb, say when the patient's going upstairs, moderate being on the flat, say if going for a walk, and severe being at rest. So as always, we think of conservative management before diving into talking about drugs. In terms of conservative management, you obviously first want to think, is there a treatable underlying cause? For example, hypertension, valve disease, or indeed ischemic heart disease. You then want to salt restrict the patients, as patients with heart failure often have an increased concentration of sodium in the body, which can contribute to the pathology. You think about graded exercise, which has been shown to be of benefit. You think about modifying their risk factors, for example, modifying dietary intake and also advising them to stop smoking. And then finally, you think about vaccination, as these patients have been shown to benefit from pneumococcal vaccination in particular. So there are essentially two goals in treating cardiac failure. You wish to reduce the symptoms and you wish to prevent death. In terms of symptomatic treatment, the most important agents are diuretics. Diuretics work by essentially increasing sodium excretion. If you increase sodium excretion, you also increase water loss. If you increase water loss, you decrease preload, that's the amount of blood entering the heart, and therefore you decrease congestion, both systemic, which leads to edema, and pulmonary, which leads to pulmonary edema. I'm going to do another whole podcast on diuretics, but just to say that the important classes of diuretics to be aware of for heart failure are the loop diuretics, such as furosemide, which if you remember we use in acute or decompensated heart failure, and bumetanide, which is a very strong diuretic, and the thiazide diuretics, such as benzoflumethiazide, which you may be familiar with in the management of hypertension, and also metolazone. This is just a little diagram to show the different strengths of diuretics. The weakest diuretics of all are the potassium-sparing diuretics, drugs such as amiloride. Next come the thiazides, that's benzoflumethiazide and metolazone, and the strongest diuretics of all are the loop diuretics, including furosemide and bumetanide. However, more on these later. In terms of preventing death, there are 4 agents that have shown to be of benefit. These can conveniently be remembered using the small mnemonic or small group of letters A, B, S, D. A is for ACE inhibitors or ARBs, B is for beta blockers, S is for spironolactone, and D is for digoxin. Remember that most of these agents, as well as preventing death from cardiac failure, also improve symptoms. Let's start with ACE inhibitors. ACE inhibitors are angiotensin converting enzyme inhibitors that, of course, inhibit ACE as well as kinase 2. This results in reduced activation of the renin-angiotensin-aldosterone system, which ultimately leads to less vasoconstriction secondary to angiotensin 2 and aldosterone secretion. This reduces both preload and afterload, which of course is of benefit in CCF. Important examples of ACE inhibitors include ramipril, captopril, enalapril, and the newer perindopril. Heart failure is particularly associated with chronic activation of the renin-angiotensin-aldosterone system. And while this is initially of benefit to patients who have reduced ejection fractions, in the long term it leads to a number of complications such as edema and increased incidence of arrhythmias. Therefore, the aim of giving ACE inhibitors in heart failure is to reduce this chronic activation. So, a few key points. All patients with heart failure, that's NYHA class 1 to 4, should receive an ACE inhibitor. And the important study here is the SAVE study. Important other principles are to start very low, as ACE inhibitors can have some important side effects, which we'll talk about in a second, but we wish to aim to increase to the highest tolerated dose. as it's been shown in other studies that the higher the dose, the greater the benefit. So what are some of the important side effects and interactions to be aware of with ACE inhibitors? The side effect which you'll probably be most familiar with is cough, which can occur in up to 20% of individuals started on an ACE inhibitor and is thought to be associated with inhibition of bradykinin. This should really be treated by changing from an ACE inhibitor to an ARB, which we're going to talk about in a sec. Other important side effects include edema, particularly of the ankles, hands and face, hyperkalemia due to reduced aldosterone, and renal failure as represented by a rise in creatinine. It is for this reason that patients started on an ACE inhibitor should have their renal function monitored. And if a greater than 30% rise in creatinine is seen, then an alternative drug should be considered. Important interactions to be aware of are with NSAIDs and potassium-sparing diuretics. The combination of NSAIDs and ACE inhibitors tends to worsen any renal effect that the ACE inhibitor may have, and therefore increase the creatinine and possibly lead to renal failure, while with potassium-sparing diuretics, you're worried about worsening hyperkalemia. Finally, the only real absolute contraindication apart from pregnancy for ACE inhibitors is renal artery stenosis, for the reasons already outlined. So the next class of drugs, and the useful alternative to ACE inhibitors if they're causing a cough, are the angiotensin receptor blockers. These have their action at the AT1 receptor, where they reduce aldosterone and vasoconstriction. There are two broad types, the short-acting ones such as losartan and the long-acting ones such as irbesartan and candesartan. There are two important trials to be aware of. These are the VAL-HEF trial and the ELITE-2 study. There are many others, but these are the most important. The VAL-HEF trial is important as it showed that valsartan is better than placebo in preventing morbidity and mortality associated with documented heart failure, and the ELITE-2 study is important as it showed that an angiotensin II blocker is just effective as an ACE inhibitor in terms of endpoint in cardiac failure. In terms of side effects, they are roughly the same as the ACE inhibitors, but importantly, they don't cause the cough. What is important to note, however, is that they should not be used together with an ACE inhibitor or potassium-sparing diuretic because they can cause quite severe hyperkalemia. So let's move on now to talk a little bit about beta blockers. There is quite a bit of evidence now for the use of beta blockers in heart failure. However, it would be fair to say that not so long ago, beta blockers were thought to be contraindicated in heart failure. There are evidence for particular beta blockers. These are carvedilol, metoprolol, and bisoprolol, and there are important studies to go with each of these, which you should probably know. Although initially thought only to be indicated in more severe heart failure, the most recent evidence shows that they should be prescribed in all classes of the heart classification. And as with ACE inhibitors, you should start very low and you should increase quite slowly. In the podcast on acute coronary syndrome and angina, I went through in detail some of the important side effects of beta blockers, but once again here is the table. The important ones to be aware of are bronchospasm, cold extremities, bradycardia. This is particularly important in the context of cardiac failure because bradycardia could further reduce cardiac output. Beta blockers can also cause dreams, sexual dysfunction, and can indeed worsen diabetes, particularly if used with thiazide diuretics. Also note their important interaction with diltiazem and verapamil, which may of course be used to rate control atrial fibrillation in these patients. So let's now move on to S. S is for spironolactone. Spironolactone is a fairly weak potassium-sparing diuretic, but it has been shown to increase survival in patients with most severe heart failure, i.e. those patients who lie in NYHA Class 4. And the important study here was the RAILS study. In terms of side effects, there are only two to be aware of. These are hyperkalemia and gynecomastia. Lastly, let's talk a little bit about digoxin. Digoxin was one of the first drugs actually used in heart failure, and as you will know, is derived from the foxglove plant. It is a cardiac glycoside that inhibits the sodium-potassium ATPase and has two important actions. It increases the force of contraction of the myocardium and reduces AV nodal conduction. In heart failure, it is indicated for patients who have coexisting AF, particularly fast AF, because as we know, the digoxin can reduce the AV nodal conductance and therefore help to control the ventricular rate. If you control the ventricular rate, then you place less strain on the heart and therefore will get less symptoms and improve prognosis. However, it's also thought to be indicated in other forms of heart failure, and this was shown particularly in the DIG study, where it was shown to reduce hospital admissions in all patients, but most particularly in those patients with the severest heart failure, that is, patients in class 3 and 4. In terms of the important side effects and interactions to be aware of, as you might expect, digoxin being an antiarrhythmic interacts with amiodarone and is also contraindicated in Wolff-Parkinson-White syndrome. However, there's going to be a separate podcast on antiarrhythmics. In terms of the important side effects, digoxin often causes nausea and vomiting, but the real danger is toxicity that can actually cause fairly severe dysrhythmias. Importantly, however, digoxin toxicity may be reversed using digoxin antibodies such as Digibind and Digifab. Finally, here is a nice ECG showing the manifestations of digoxin toxicity, and the thing to remember for your exam questions is the characteristic reverse tick appearance. Note also that digoxin toxicity is increased by exposure to abnormal endocrine and electrolyte disturbance, particularly hypokalemia, hypercalcemia, and hypothyroidism. So, in summary, in this podcast we've talked about the treatment of heart failure. We've talked about the New York Heart Association classification. We talked about some of the more conservative things that you can do to manage heart failure. We talked about nitrates and the important role that they have in treating patients' symptoms. And we've talked about the ABSD group, i.e. those drugs that have been shown to provide prognostic benefit. These include an ACE inhibitor, which of course can be substituted with an ARB if there's a troublesome cough, beta blockers, particularly carvedilol, bisoprolol, and metoprolol, and spironolactone and digoxin that are usually used if the heart failure is more severe, that is class 3 or 4. So thanks for listening and see you soon.